Hello, welcome to this YouTube channel. So today we're going to discuss on ectopic pregnancy. So we're going to discuss on its definition, risk factors, pathophysiology, clinical manifestations, how to diagnose and how to manage, and its complications. So please help me by subscribing to my YouTube channel because I need your help to produce more videos. So let's get started. So starting from the definition of ectopic pregnancy is very simple. When a fertilized ovum is implanted and it develops outside the normal endometrial cavity, that's called ectopic pregnancy. Normally, the implantation site for the fertilized ovum is inside the uterus. So if it is outside the uterus, that is called ectopic pregnancy. As you see from the picture, this is the uterus, this one is the fallopian tube, and this one is the ovary. We have a vagina here, and this is the cervix. So the normal implantation site is this one, the uterus, the fundal part of the uterus. So if it is outside this, that's called ectopic pregnancy. So it has different sites. It's at different sites. It could be tubal, ovarian, or it could be cervical or abdominal. So the tubal one is the most common. It's around 95 to 96% is the tubal ectopic pregnancy. So the tube also has different parts, starting from here, that's interstitial or corneal, isthmatic and ampullary, and also fimbrial part. So the ampullary part is the most common side of tubal ectopic pregnancy. That's the most common because it is the widest part where where fertilization is to just happen. Here is the most common sites of ectopic pregnancy. Then there is ovarian. There could be cesarean, scar, ectopic pregnancy. There could be just cervical, even abdominal. In very rare cases, abdominal ectopic pregnancy will occur. So this is the site and the definition. The risk factors, before we're going to discuss on risk factors, we have to know the mechanisms of zygote movement. You know, the zygote should be transported from the fallopian tube to the uterus. So what mechanisms moves the fertilized egg from the fallopian tube to the ovary? So we have two main mechanisms. The first one is tubal peristalsis. Tubal peristalsis means, a rhythmic contraction and relaxations of the fallopian tube that pushes the egg toward the uterus. So that's the contraction and the relaxation of the tube. The second one is tubal ciliatic movement. There are cilia, hairy-like small structures inside the fallopian tubes, which push the fertilized egg toward the uterus. You can see from this picture. As you see from this picture, these are cilia. So when look like this, they push, the cilia pushes the fertilized egg toward the uterus. So anything that interfere with these two mechanisms, that could be a risk factor for ectopic pregnancy. To see a few of them, for example, history of PID. PID means pelvic inflammatory disease, where the upper part of the reproductive system, the reproductive organ, are damaged by infections, usually gonorrhea or chlamydia. So this PID will reduce the amount of cilia. Also, it affects the movement of the tube. So that will be the risk factor for ectopic pregnancy. That's the most common risk factor. The other is tubal ligation, contraception failure. The contraception just reduces the absolute risk of ectopic pregnancy. But if the contraception method fail, that increases the pregnancy to be ectopic. Previous ectopic pregnancy, that's the greatest factor of ectopic pregnancy. PID is the most common one, and previous ectopic pregnancy is the greatest risk factor. So if there is previous ectopic pregnancy plus tubal reconstructive surgery, these two are the main the greatest risk factor. They have the tendency to have ectopic pregnancy. History of infertility, ART, artificial reproductive therapy for infertility, that increases also the risk of ectopic pregnancy. Intrauterine device, that also increases, especially with the hormonal one, especially with progesterone, like Mirena. They're the greatest risk factor. There are also previous induced abortion, where the implantation site of the uterus is not favorable, so the fertilized egg will move to other area. Tubal endometriosis, which affected the shape and the motility of the fallopian tube, so that will be the risk factor. So these are some risk factors. PID being the most common, and previous ectopic pregnancy the greatest factor. Okay, to see pathophysiology. So the outcomes of ectopic pregnancy could be usually, I'm talking about the tubal one. So there will be tubal rupture or tubal abortion, or there will be pregnancy failure, where the pregnancy is absorbed there in the tube. So in tubal rupture, since the tube cannot hold the growing fetus inside it, so the tube will rupture, and that causes massive bleeding, and the patient will be in a shock. Tubal abortion, where look from this picture, the tube is, the implanted site of the ovum or the embryo is aborted, then it will just go outside of the tube to the abdomen. It will be absorbed, or it will implant secondarily in the abdomen. So that's outcome of ectopic pregnancy. So the course would be acute or chronic. In acute is the most common one. There will be high amount of HCG, which is a hormone which is produced by chorion, and also there will be a rapid growth. So that rapid growth will increase the risk of tubal rupture. In chronic, it is less common, repeated rupture, but not totally. A small repeated rupture, and tissue will die. That leads to negative or very low or very, static amount of HCG will be produced. So that's the pathophysiology. Okay, clinical manifestations. So the clinical manifestation depend on whether it is acute, whether the tube ruptured or unruptured, or whether it is chronic. In acute one, so it's usually the acute course is usually with ruptured tube, associated with ruptured tube. There will be, there is a classic threads of ectopic pregnancy, the three symptoms of ectopic pregnancy. So abdominal pain with amenorrhea with vaginal bleeding, these are the classic triad of ectopic pregnancy. So other symptoms like shoulder tip pain due to the irritation of phrenic nerve, or due to irritation of diaphragm with the bleeding inside the abdomen, and also there will be a vomiting, there will be a fainting, or there will be a shock. So these are symptoms. So signs, or the thing that you can observe, like deranged vital signs, the pulse rate will increase, also the blood pressure will decrease, or she could be hypotensive, there will be pallor, abdominal tenderness and the guarding, and shifting dullness, feature of shock will be observed in acute phase. In a ruptured one, where the tube is not ruptured, so delayed period, that's amenorrhea plus spotting with features of suggestive of ectopic pregnancy. Urine HCG will be positive here. Then flank pain, which is continuous or at times of colicky in nature, and also signs you can assess sign of pregnancy, and also well circumcised tender mass will be observed in a ruptured one. And if it is subacute or chronic, symptoms are onset is insidious, previous attack which is recovered, lower abdominal pain with a varied degree, and scanty vaginal bleeding, not massive but scanty, or others like rectal tenesmus, dysuria, and fever is associated with an infection. Though the other is signs, pallor, tachypnea, and but there's no shock. Temperature will be increased, tenderness on exam, and also mass or colon signs, where around the umbilicus you observe these colon signs. Okay, how to diagnose? So the diagnosis encompasses history and physical exam, lab investigation, sonography, laparoscopy, and laparotomy, and also other like cholecystosynthesis and dilatation curettage. From history and physical exam, you can assess the risk factors, and you can assess from abdominal exam and vaginal exam, so you'll find some findings. From the lab investigation, you can use urine HCG to rule out whether the pregnancies exist or the pregnancy is positive or not, and also serum beta HCG, which is very important. It has three functions: doubling time, discriminatory level, and follow-up. When I say doubling time, if the pregnancy is inside the uterus, or if it is normal pregnancy, the amount of HCG in 48 hours will be greater than 53%. Some books say 66, and also some books say 35, but 53 is the best one. So 53%. About 53% will be increased in HCG. In ectopic pregnancy, that will be less than 53%. The amount of HCG in 48 hours is less than 53%. So first you measure the amount of beta HCG, then you see after 48 hours. So if it is normal pregnancy, it will increase by greater than or equal to 53%. Discriminatory level is used with ultrasound. On transabdominal ultrasound, if the amount of beta HCG is greater than 6,000 international unit per milliliter, it should be observed by ultrasound, or it should be observed by transabdominal ultrasound. For transvaginal ultrasound, it should be visible when the amount of beta HCG is greater than 3510, that is 3,510 international units. This was previously 1,500 to 2,000, so this one is the updated version. This one is updated. Some books says lower, but some says this is the most common one, and it also used as for serial management in whether the amount of HCG is declined or static or increased. So it uses for follow-up. Okay, the other is progesterone level. Progesterone level is not good method to diagnose, but it will assist. So the amount of progesterone in normal pregnancy is between 5 to 25 nanogram per deciliter. So if it is outside this range, that suggests the pregnancy is not normal. Sonography, which is very important, especially transvaginal sonography is very important with conjunction with beta HCG together. So if it shows empty uterus with beta HCG above discriminatory level, that means around 35-10, that suggests ectopic pregnancy. Now, we can't say totally or 100% ectopic, but it is most highly suggestive of ectopic pregnancy. If it is below discriminatory level and TVS shows empty uterus, that's called pregnancy of unknown location. We don't know the location of the pregnancy. It could be intrauterine with the early pregnancy, usually when the pregnancy is not enough to be visualized by ultrasound. So that needs serial HCG measurement. We have to measure the amount of HCG continuously, and if it is increased and if the uterus is empty, that suggests ectopic pregnancy. The other, it can show gestational sac, fetal heartbeat, or fluid coagulation or hematoma, masses. If the tube ruptures, it is possible to observe some hematoma and masses. So the other is laparoscopy or laparotomy. When you say laparoscopy, we insert a camera into the abdomen, so we can observe inside the abdomen. So that's the very important and the gold standard. If this one is impossible, we have to open the abdomen and we have to see the inside part of the abdomen. So that's called these two are very gold standard. We can just assess 100%. So laparoscopy is very good for a stable patient. For stable patient, that's good. But if she is unstable and she is hemodynamically unstable, we have to open the abdomen and see it. The other cholesynthesis, which is aspiration of cul-de-sac. If there is aspiration of when you aspirate, you insert long needle into the vagina, then into the posterior fornix of the vagina. So there is a cul-de-sac space called cul-de-sac. Then you aspirate some fluid from that, and if that fluid has contained non-clotting fluid, so that suggests this bleeding, so that suggests this ectopic pregnancy. So if there is no clotting, or if there's no blood, and if there's no aspiration at all, that suggests this ectopic pregnancy is unlikely. D and C, which is dilatation and curettage, we dilate the cervix, then we correct the uterus. If we find a decidua with a chorionic villi, that suggests this ectopic pregnancy. But if there is decidua plus chorionic villi, that suggests this intrauterine pregnancy. Okay, differential diagnosis. When it's a differential diagnosis, these diseases have similar clinical manifestation with ectopic pregnancy. So incomplete abortion, salpingitis, which is inflammation of fallopian tube, appendicitis, twisted ovarian tumor, ruptured corpus luteum. So these are differential diagnosis. So you can read by pausing the video. You can read this how to differentiate them from ectopic pregnancy. I'm not going to read these all points. So read it. Okay, when it comes to the management part, so the management could be expectant management or medical or surgical. When you say expectant, we're just following the condition of the woman. So in order to use expectant management, we have to have some criteria. So initial beta HCG level should be less than 1,000, and it should fall subsequently. Gestational sac should be less than 3 centimeters in transvaginal ultrasound. No fetal heartbeat is seen on TVS or transvaginal sonography, and also no evidence of bleeding or rupture. So during this time, we can just follow the pregnancy. For medical, we use methotrexate. This is a drug. So to use methotrexate, we have to have some criteria like hemodynamically stable women, serum beta HCG should be less than 3,000, and also gestational sac should be less than 4 centimeters, and there should not be a tubal rupture, no cardiac activity is seen. So that's this woman will take this medical management. For surgical, that's laparoscopy or laparotomy. And when we say laparoscopy, we insert the camera. So we can just visualize it, and it could be both diagnostic or therapeutic. In laparotomy, we open the abdomen, so there could be salpingotomy, salpingostomy, or salpingectomy. So if ruptured, always that's salpingectomy. We have to remove the fallopian tube. So if the woman is Rh negative, then we have to give anti-D gamma globulin. Okay, so these are some complications like rupture of fallopian tube, internal bleeding, hemorrhage, shock, infertility, infections, peritonitis, and psychological impacts are some complications of ectopic pregnancy. Okay, and to have a more deep knowledge, I suggest you to read these books. And thank you for watching, and please subscribe to my YouTube channel so that you don't miss my latest videos.